Hello, my name is Sandip Singh and my final video presentation is on HIV and AIDS. And I also go into discussion about a research study that I found interesting. First, I will give a brief introduction about what HIV is. The human immunodeficiency virus, or HIV, is a chronic virus that attacks the immune system of the body, targeting specific white blood cells called T cells. HIV is a retrovirus that carries its genetic information in RNA. When a person is infected with HIV, it will travel through the blood and bind to helper T cells, which are the command center of the immune system. Once inside the cell, HIV can direct a T cell to produce many new viruses, which could be released out of the blood and infect new cells. Over time, HIV destroys more T cells, which leads the body to become more susceptible to other diseases, especially cancer and life-threatening diseases like pneumonia. When an HIV-infected person's T cell count reaches about 1/6 the normal level, they are diagnosed with acquired immunodeficiency symptoms, or AIDS. Many researchers believe that the first cases of HIV and AIDS originated from chimpanzee species residing in West Africa. Humans may have contracted the virus through animal blood while hunting. The HIV/AIDS epidemic was first reported in the United States during the 1980s, even though it arrived during the 1970s. Physicians began reporting serious infections produced by microorganisms that didn't normally cause disease. In the summer of 1981, 5 young, white, healthy gay men were hospitalized for a rare lung infection. Doctors in the Los Angeles hospital where these men were treated said that the men had compromised immune systems, although they had been healthy before. During the early stages of the disease appearing in the United States, AIDS was commonly called GRID, or gay-related immune deficiency, because it was common in gay men. However, a couple of years after the disease was first discovered in the United States, the CDC also reported cases of disease in female partners of AIDS-positive men, meaning that the disease could be transmitted through heterosexual sex. Cases of patients also developing HIV through blood transfusion became common. Needle sharing with an HIV-positive person to inject drugs and donation of blood from infected people caused a surge in cases. As researchers learned more about the disease, the first HIV test was developed by the FDA in 1985 that could detect HIV antibodies. 2 years later, the first antiretroviral medication was introduced for HIV, AZT. This drug prevented the virus from multiplying, allowing the immune system time to recover and fight the virus. Recently, in 2012, the FDA approved PrEP for HIV-negative people, which reduces the risk of contracting HIV during sex. There are a few ways that one can get HIV, and most of them involve the transmission of bodily fluids from someone that is already HIV positive. Bodily fluids include blood, semen or preseminal fluid, rectal fluids, vaginal fluids, and breast milk. When one does develop HIV, several symptoms take place. Because HIV is a chronic disease, these symptoms happen in 3 stages that eventually lead to AIDS. Stage 1 is known as acute HIV infection, and the symptoms usually develop 2 to 4 weeks after transmission of the virus. These symptoms include fever, night sweats, mouth ulcers, swollen lymph nodes, and fatigue. During stage 2 clinical latency, the virus is still multiplying, but at a very low level compared to stage 1. This stage also lasts longer than stage 1 and is more chronic. Without the right treatment, this stage can last for years. The final stage of HIV is AIDS, in which the immune system is severely weakened. Someone with AIDS is significantly prone to contracting viral diseases and infections, and some of the symptoms that develop during this stage may be a result of contracting infectious diseases. Symptoms of AIDS include rapid weight loss, recurring fever, tiredness, and swelling of lymph glands. According to the United Nations Program on HIV and AIDS, there are about 37.9 million people around the world living with HIV. It has infected millions of people around the world, especially in developing countries, where access to healthcare systems has a profound effect on the number of people who have become infected and are unable to receive treatment. Between 1981 and 1991, the global cost of the epidemic was reported to have reached $240 billion, and with an estimated daily global cost of $250 million, AIDS would soon absorb $500 billion annually, equivalent to 1% of the world gross national product. Along with the economic impact comes the social impact and discrimination that people who are infected with HIV face. In many parts of the world, especially in developing countries, families are the main support for people living with the epidemic. However, low-income families may not be able to afford treatment costs of HIV, sometimes causing a strain in the relationship between the infected individual and their family. In many countries, HIV-positive women also face unjust treatment, being left alone by families to fend for themselves and even held accountable for spreading the epidemic in their communities. As stated before, there are about 37.9 billion people around the world with HIV. 1.7 million people are infected each year. According to the KFF statistics and seen on this map, South Africa has the highest number of people living with HIV in the world, around 7.7 million. In Asia, an estimated 5.9 million people are living with HIV. However, the country has a relatively low prevalence, even though it is highly populated. North American and European countries have an estimated 3.9 billion people living with HIV. South America has around 1.7 million people, and with a growing number of people receiving treatment and effective preventative programs, HIV incidence rates have been decreasing over the years. Now I will talk about my GIS-based case study. The title of this research paper was Geographic Information System-Based Screening for TB, HIV, and Syphilis, a cross-sectional study. It was published in 2012, and the authors' names are listed here. The purpose of this article aims to identify areas of low-income communities in the United States that were vulnerable to disease transmission, including HIV, using Geographical Information Systems, or GIS. This study took place for 2 years between January 1st, 2015 through December 21st, 2007 in Wake County, North Carolina, along with obtaining the addresses of the participants or people that lived in the proximity of the hotspots. The demographics and behaviors of the participants were also collected. This included race, tobacco use, alcohol abuse, IV drugs, crack cocaine, number of sexual partners, and prior STD reports. So I have separated the factors that are included in the study into the 3 different vertexes. For habitat, the study took place in Wake County, North Carolina, and it was usually with low-income communities. The population vertex included participants in the study that lived in the high-risk areas of being infected with HIV, tuberculosis, or syphilis. And the behavior vertex was the use of IV drugs, crack cocaine, sexual behaviors, demographics, and education levels. The authors used a cross-sectional study methodology design of all participants that were vulnerable or lived in the hotspot areas of the disease transmission in Wake County, North Carolina. So because this was a cross-sectional study, I've separated the groups of exposed and non-exposed groups, as well as diseased population and non-diseased. So first, diseased population and exposed groups included all the people that were infected with HIV, syphilis, or TB and lived in the hotspots. Diseased population and non-exposed groups were all the people that were infected with HIV, syphilis, or TB, but they did not live within the hotspot. The non-diseased population and exposed group were all the people that were not infected with HIV, syphilis, or TB, but they lived within the hotspots. And finally, the non-diseased populations and non-exposed groups were all the people that were not infected with HIV, syphilis, or TB, and did not live in the hotspot. And above is a map. It shows where the hotspot is located, or the study area, which is outlined in red, and the population density of Wake County. So the researchers of the study used ArcGIS software to map the 3 areas where the 3 diseases had the highest amount of cases over the past few years. And based on the map created for Wake County, it was found that there were 150 tuberculosis cases, 155 syphilis cases, and 655 HIV cases. They collected cases as people who lived in these hotspot areas, and these people were either screened for HIV, syphilis, or tuberculosis. So this slide shows the results of the study, and it can be clearly seen that the prevalence of HIV, tuberculosis, and syphilis was actually higher based on the GIS study than what was actually known beforehand with the health department clinic. The demographics also show that African Americans that lived in the communities were at higher risk than, say, Hispanic or white, and males were also at higher risk. So the results of the study indicate that there was a higher prevalence of HIV infection in the hotspot areas of Wake County than what was reported in the health department STD clinic of the area. Many of the participants in the case study had high-risk characteristics. that were collected during the study, which included living in homeless shelters, use of crack cocaine, and prior incarceration. This study also showed that using GIS data to indicate which areas were at higher risk than others allowed proper use of limited healthcare testing and treatment. Multi-screening of the various diseases was effective for areas that had limited resources and assessed individuals who showed high risk of all three diseases. So this article was very useful in my research topic because it displays that lack of testing in low-income communities means that there may be higher prevalence of HIV than what is known. It also shows that using GIS to collaborate with low-income communities and healthcare facilities in these areas to potentially lower the case rates of HIV and other infectious diseases. The main limitation of this article was that the study only occurred in one county and the population was very small to have everyone assessed. However, there are many low-income communities like Lake Wake County around the United States that have limited treatment resources, and the study should also be replicated in those areas. So that is the end of my presentation, and these are my reference lists.